So in multiple myeloma, many things have changed over the past 5 to 10 years. Certainly, we've seen a revolution of therapies. There are new ones available, and we've repurposed drugs that were only for relapsed refractory and brought them closer to the front line. At this year's ASH, we'll be seeing more of that data. For example, there will be 2 abstracts looking at carfilzomib, Revlimid, and dexamethasone in combination with daratumumab for newly diagnosed myeloma. So I think that's really pushing things up front sooner in therapy rather than waiting for people to relapse. In addition, there's been a lot of new data with immunotherapy, and a lot of that is going to be updated as well. In particular, we'll be seeing the first data from a longer-acting bispecific T-cell engager from the Celgene data, and so we're very excited to see what the response rates there. Preliminarily, at their active dose, it looks like 83%, which is great, and there will also be updated data on chimeric antigen receptor T-cells. Yeah, over the last couple of years, multiple myeloma has changed in some ways and in some ways not. I think we've all figured out that triple therapy, meaning 3 drugs, is better than double therapy. And so it is known that as you start to treat patients who you think are relatively fit, those patients should get triple therapy. But what drugs those patients get is starting to be a little bit more in question. So for example, the SWOG data a couple of years ago published confirmed that Velcade, Revlimid, and dexamethasone, or VRD, was a treatment of choice for newly diagnosed myeloma. But since then, there have been other publications and also pending studies that may show us that perhaps carfilzomib, Revlimid, and dexamethasone, or KRD, is better. And even still, there are publications with quadruplet therapy that incorporate daratumumab. For example, daratumumab, Velcade, thalidomide, and dexamethasone, which was published recently, the Cassiopeia trial, showing that there's an advantage for quadruplet therapy over triplet therapy. So our drugs have kind of moved faster than our trials have, and so now we're really looking to incorporate newer drugs and maybe more of them up front for therapy.